everyone. This is Varsha Singh, and I'm your host for Healthline on TVAsia Telugu channel. I bring you a special guest every week, and this special guest, which is a physician, a healthcare provider, with something special about his practice or her practice, their expertise and their knowledge and the information that brings you a lot of knowledge to take care of your health. This episode, when you watch, you take home a lot of tips, everything that you can use in your day-to-day life to improve the quality of your life through preventative practice, proper treatment, or just learning about different specialties so that you have your awareness about your health. So without further delay, I'm going to introduce a special guest that is in our studio today. Our special guest is Dr. Mathew Hosler. Dr. Mathew Hosler is an ophthalmologist, a certified ophthalmologist who is also a glaucoma specialist, a cataract specialist, and a macular degeneration specialist. You might be wondering, what are all these conditions? But I will let him explain all that to you. Dr. Mathew Hosler has a long resume and a very impressive one. Dr. Mathew Hosler has gone to University of Pennsylvania for his undergrad studies. Then he got his medical degree from Rutgers Medical School, which is right here in New Jersey. After that, he has completed his fellowship or post-graduation fellowship through Penn State University College of Medicine and NYU. Dr. Hosler has written 14 peer-reviewed articles on glaucoma treatment. And he has published this along with Dr. Robert Pitch and Dr. Celso Tello. Dr. Mathew Hosler is not just a certified ophthalmologist. In his spare time, he is also an assistant coach in Cranford, where he is teaching softball and baseball, which really explains and it gives an idea about his personality that while he is practicing eye medicine, making people see better, he is also donating and volunteering his time to teach games to young generation. So please welcome Dr. Mathew Hosler. Hello, Dr. Hosler. Welcome to Healthline, TVAsia Telugu channel.
Hi, Varsha. We've worked together over the years through Robert Wood Johnson University Hospital in Rahway. It's a great pleasure to see you again. Thank you, and it's a privilege that you invited me. Thank you.
So, Dr. Hosler, going back to what you said, yes, it was really a great pleasure meeting you. I would say almost 8 years ago, when I was working in a different environment, and I had a lot of patients who did not have insurance, and these patients had diabetes and hypertension, and this is a population that really needs care of their eyes. I remember that you partnered and you agreed that yes, I will see these patients in my clinic, and together we actually completed a really great project that took care of a lot of non-insured patients who could not afford eye consultation or eye classes. So that really is your philanthropic partnership that helped a project. So I'm really pleased to have you in this show and give everyone an opportunity to know you.
Thank you. I appreciate it. Thanks.
And I'm really looking forward to all our viewers to learn about their eye health and how to take care of their eyes. So my first question will be, Dr. Hosler, please tell our viewers a little bit about your practice and what you do.
Okay, so we have 4 locations in this area. The closest to, I think, the viewership area are locations in Rahway and Union. I do a mixture of what we would call comprehensive ophthalmology and glaucoma medicine. So, you know, to give an overview of what an ophthalmologist does, our the key to what we can offer are the surgeries that we do. And the most common surgery performed by a comprehensive ophthalmologist is cataract extraction. And we'll talk a little bit about that throughout speaking, going forward. The other things that we do really focus on diagnosing diseases that emanate from the eye itself, or the eye socket, which we call the orbit, or problems with the extraocular muscles, eyelids, or the connections, the neural connections between the eye and the brain. And so, as far as, I guess I'll just summarize really what you might expect, or why your viewership, should see a specialist like myself at some point in their life, would be to screen or rule out certain common eye diseases. I mentioned the extraocular muscles and neural connections, but really the thing we do the most and the most effective is diagnose and treat cataracts. We screen for several other common diseases. I would say the three most common I would want your viewers to think about would be diabetic retinopathy, if they have diabetes, and glaucoma, which is sort of the way eye pressure, or sort of the way systemic blood pressure would relate to a heart attack risk or stroke risk. Eye pressure relates to the chances of damaging the optic nerve. These are things that can often, totally occur in patients over the age of 45. And then so there's diabetes, glaucoma, and then the other most common thing we look for is macular degeneration.
Okay.
Again, which is something that rarely emerges below the age of 50. But
okay.
One thing I would say about this, as far as when would it be time to see an ophthalmologist, would be there are many patients who don't ever require glasses for driving. And they only may, for the first time, need to pick up over-the-counter readers at the drugstore when they hit their 40s. Patients like this, sometime in their 40s, their primary care doctor may recommend, hey, you've never had your eye pressure checked or something like that, you better go get a screening exam. And in fact, many patients, if they're otherwise healthy, especially if they don't have diabetes, many of them will find that access is actually much easier to an optometrist. So
wonderful.
Yeah, so the distinguishing feature between optometrist and ophthalmologist is the surgery factor. Optometrists do an excellent job at prescribing glasses and contacts. They do an excellent job generally with eye health exams. If they find a cataract or they find glaucoma or macular degeneration, many times they'll refer to us. But it's in the 40s.
Wonderful.
For patients who've never been seen before, it's time to start thinking about seeing an optometrist or an ophthalmologist.
Let me ask you a very basic question.
Yes.
Thank you for sharing about what you do as an ophthalmologist, and I believe you also distinguish or differentiated between what an optometrist is versus an ophthalmologist.
Mm-hmm.
So if we can really make it simpler for our viewers to understand, let's start with my basic and very fundamental question. What is eye health, and what does it mean when we say you need to take care of your eyes?
Okay. I would, really consider, I think I kind of implied this, but I just would expand on the fact that, diseases, most of the diseases that can affect your eyes are really an extension of your body, the health of your body. So for instance, when your family doctor or your cardiologist or someone diagnoses you with diabetes, of course we have to worry about end organ damage. Is your EKG normal? They check the BUN creatinine in the blood to make sure your kidneys are functioning normal. Anyone who has a new diagnosis, for instance, of type 2 diabetes, they should have an eye exam within a month or two. It's not an emergency, but the eyes need to be considered as another end organ when you have diabetes. And so eye health really, in its most basic form, is to correct any focus abnormalities with glasses. And then you just need an ophthalmologist or optometrist to examine the eyes with a microscope, a slit lamp. Actually, this is one right here, a slit lamp microscope. And those microscopes really can check the eye pressure, the intraocular pressure, and they can detect all the things I mentioned. The same way your family doctor will always check your blood pressure with a sphygmomanometer, with a cuff. The only way to check the intraocular pressure or the pressure inside of the eye is with the tonometer that comes with the slit lamp or a similar instrument. And these type of functions are segregated to ophthalmologists and optometrists. There's no family doctors at this point who can check eye pressure. We're thinking about instituting things like this, but those are things that are coming down the pike.
So Dr. Hosler, I heard that you mentioned around 40 people start getting about double vision, and they have to make sure that they at least have their examination schedule when they're at 40.
Yes.
But let me ask you, what about small children?
So
at what point you would recommend that they should be seen by an ophthalmologist?
That's a very good question. So really systemically in the United States and many other places, the children's vision, there are some cursory exams that your pediatrician will monitor you for. Generally, they start with detailed exams of vision in the pediatrician's office when children become verbal and can read letters. Sometimes, so that's usually around age 4 or 5. Children generally will get a screening exam reading a reading chart in kindergarten, I believe, in many schools. So what do we do before that time? Red flags or signs that parents should be aware of to seek out, and there's actually subspecialists among ophthalmology. They're called pediatric ophthalmologists or strabismus specialists is another term. Reasons to seek out a pediatric eye specialist would be if you see a child's eyes turning in or turning out, or if they're squinting a lot. They used to call this, I think in England, they call this term squint. If you have a pre-verbal child that's squinting to see better, that can be an indication that they need eyeglasses. And the reason with either of these things, if it's squinting or a misalignment of the two eyes, if they're not straight together, you want to get that seen promptly, because if the brain does not receive an equal image from each eye, particularly between the ages of birth and 7 years old, you can develop something. The colloquial term is lazy eye. The medical term is amblyopia. What will happen is the brain will select and favor whichever eye gives a sharper image. And in that critical time in development between birth and age 7, the brain can develop normal connections with the better seeing eye, and it will fail to equally develop normal connections in the other eye, and they call that a lazy eye or amblyopia. Generally, if that happens, for instance, a child presents at the age of 6, and the specialist tries to correct their vision. They may see 20/20 in their strong eye, but even with the proper glasses, they may see, the best they could see is 3 lines larger in their other eye. In many cases, that difference or that weakness could be permanent. We want to catch that difference as early as we can. And pediatric eye specialists, sometimes only with eyeglasses, and sometimes they have to do a patching therapy, where for several hours a week, the child has to patch their good eye. we want to catch those things as early as we can. If you catch that at age 2 or 3, the potential to develop the weak eye normally is much higher than if we catch it at 6 or 7 or 8. But generally, it's some kind of behavior that suggests that either the child's squinting or not seeing. Sometimes, some parents sometimes will report that the child doesn't know its mom until she's 3 feet away. That might suggest that that child's nearsighted. So looking for that now. And before I forget, there's one other very critical thing. And in today's day and age, it's very interesting with social media and Facebook. There have been reports of children whose eye conditions, whether it's a misalignment or if it's something called a retinoblastoma, or basically you want to look and see if the coloration of each pupil is equal.
Mm-hmm.
If you see that one pupil looks black and normal and the other one looks whitish, that sometimes can be a warning sign that there's a retina abnormality or retinoblastoma.
Mm-hmm. So so I just wanted to ask you, Dr. Hosler, that would you recommend that if parents are noting some questionable behavior in children, and it's really important that they speak about it to the pediatrician during the annual well visit, or make an appointment if they have any behavior which is different, such as cannot read or cannot recognize, or they have difficulty managing their school assignment. All those things are red flags, which they can definitely discuss with their primary provider, primary pediatrician, and then they can make a consultation or referral to an ophthalmologist.
Yeah, and I would just say you mentioned an annual well visit or something like that. If a parent sees the eyes are turning in or out, if the child's annual visit's not due for 6 or 8 months, I would not wait for the next pediatric checkup. I would either call the pediatrician or speak to the pediatrician's nurse and say, hey, I think there's an eye problem here. Should I come directly in, or should I go straight to, do you recommend a pediatric ophthalmologist? Especially, really, the eyes turning, that pertains to that. But especially if you see a white pupil, the term is leukocoria, actually. If one of the pupils is looking whitish, that really should be seen right away. That they need to go to the emergency room that evening. But if I met a child at a social gathering, I would tell the patient's parents to call the pediatrician tomorrow. It needs to be seen right away.
That's a great tip.
Yeah.
Dr. Hosler, coming to the next question.
Yes.
I know that when patients go for their annual eye exam, there are a couple of outcomes. Number one, you examine the patient and say, hey, everything is fine, go back, do what you're doing. Your eyes are fine. Many patients like to hear that.
Yep.
At least they got it checked out, my eyes are fine.
Yep.
But then there are patients with chronic conditions like hypertension and diabetes.
Right.
And we talked about glaucoma. And if you can elaborate on, because I'm not sure many of our viewers are aware of what is glaucoma, other than just that I have eyeglasses. I can't see far, I can't see near.
Yes.
So I think we really need to focus on glaucoma because it is a dangerous condition.
Right. And so I'll start with glaucoma. I sort of touched on that. The vast majority of patients who do have glaucoma, they usually develop it, the late 40s, or the most of them are really around age 50 and beyond. It is, in the vast majority, it's completely asymptomatic. And it can go on for 5-7 years. The patient has no idea. And then if they're feeling well and they see well, they don't really need glasses, but they never get their eyes checked, they may have elevated eye pressure. If it goes on for a few years unnoticed or unmeasured, they can present to me with damage to their optic nerve. So the typical course of early glaucoma in someone is elevated eye pressure and damage to the optic nerve. The optic nerve is like a cable. It connects to through the back of the eye, and then it passes through the orbit, and then it connects to the occipital cortex. And it's damaged when you have high eye pressure. It's damage to the spot in the eye where the optic nerve enters. It's called the optic nerve head. And when we look in the microscope, we can detect changes in the contour of the optic nerve head. And if we catch it, say, after it's been going on for a few years, we sometimes will see them and they'll already be starting to have a little bit of what they would call tunnel vision. In its early stages, glaucoma will cause blind spots or areas of the peripheral vision to be reduced. And many times this is asymmetric. And because the patient has another good eye that doesn't have as much deficit, with both eyes open, the brain kind of ignores it. And so that would be the purpose of getting the eye pressure checked and the optic nerves examined in your 40s or close to 50 to make sure you don't have this unknown elevated eye pressure. For eye pressure to be elevated under the age of 40 is exceedingly rare. It's probably somewhere around 1 in 5,000 individuals. But to have elevated eye pressure over the age of 50 is much more frequent. It's still not terribly common, but over the age of 50, you may see it in as many as 1 in 100, 1 or 2% of patients in that age group. So we want to get that screened for. As far as hypertension, I touched on diabetic retinopathy. What diabetes does to the retina is it causes, just the same way as your heart blood vessels or your kidney, the blood vessels in the retina can sustain gradual damage. They become, in some cases, less oxygen permeable. In other cases, they can leak fluid or blood into the retina. In its early stages, diabetic retinopathy can cause types of bleeding or fluid collection. It's called macular edema that can reduce the vision. If you have a severe or poorly controlled diabetic, their capillaries will start to shut down in the retina, and the retina becomes ischemic. If there's enough retina ischemia, the remaining blood vessels can sprout new vessels. They call that neovascularization. And that can cause all kinds of types of bleeding or even sometimes retinal detachments. Again, this doesn't happen in every diabetic, but if you look at a large group of type 2 diabetics who are checked or screened for diabetic retina damage in the first few years from their diagnosis, a lot of studies suggest 30% of diabetics on their first or second eye exam will have damage to the retina. And many of those patients early on are asymptomatic as well. So hypertension, systemic hypertension is much less frequent to cause retina damage.
న్యూజెర్సీలో ఇల్లు కొనాలని కానీ అమ్మాలని కానీ అనుకుంటున్నారా? మీ నమ్మకమైన నేస్తంగా మీ ఇంటి క్రయ విక్రయాలను చేసి పెడుతోంది మీ లోవి రియల్టీ గ్రూప్. వేలాది డాలర్ల మీ కష్టార్జితాన్ని, ఎంతో విలువైన సమయాన్ని ఆదా చేస్తూ కేవలం $990 నామమాత్రపు ఫీజుతో ఖచ్చితమైన సంతృప్తికరమైన లావాదేవీలను చేసిపెట్టే రియల్ ఏజెన్సీ లోవి. అంతేకాదు, మీరు కొన్న ఇంటి మీద మినిమం 1% క్యాష్ బ్యాక్ మీ క్లోజింగ్ కాస్ట్ లో పొందగలరు. మరిన్ని వివరాలకు ప్లీజ్ విజిట్ www.lovihomes.com. కాంటాక్ట్ 908-304-9621 or 908-337-1289.
What I'm hearing from you is, regardless whether the patients have hypertension or diabetes, if the underlying treatments are not treated, if they do not manage their primary condition well, it's going to affect their retina and cause some degree of damage through microvascular changes where they really damage their blood vessels within the eye, and it can lead to blindness if not treated in timely manner.
That's right. Yep.
So your advice is really important to those who are watching this, that I must go and make an appointment now. If you have not done it in last year, it's every year.
Actually, especially diabetics, patients with systemic hypertension is, also helpful. But yeah, diabetics really, even if you're well controlled, a diabetic patient should be having an annual eye exam with an optometrist or an ophthalmologist. Absolutely.
Yeah. So at this time, Dr. Hosler, I think it will really help if you could share a patient story, someone who had this kind of condition, and then you treated them and the outcome that you experienced. And that will really help our viewers to understand that how important it is to take care of these conditions in timely manner.
I guess I would consider, I have a patient who has glaucoma, and I've been seeing him for several years. He's about a 67-year-old African-American gentleman, and he is on 2 different eye drops to maintain his intraocular pressure. He's got pretty much normal vision in one eye. His other eye has what I was describing, has a tunnel vision. And this particular gentleman has part of that tunnel vision. It's not perfect. It's not a perfect tunnel. Many times it's not a perfect circle. This gentleman has a tunnel where, it's kind of round on the bottom, and the dark spot or the blind spot is starting to impinge on his central vision on the other side in an asymmetric way. And normal intraocular pressure is between 10 and 20. And these patients with tunnel vision, they read the chart fine. Many of them see 20/20. They can read normally in their center. This gentleman, I would see him about every 4 months, and he was well controlled. And then one time he came in, and the eye with tunnel vision, I noticed normally his pressures, I think I just mentioned the pressures 10 to 20 in most people. I was maintaining his pressures around 12 in both eyes, which is very good. Most glaucoma patients, if you keep their pressures comfortably below 18, most of their tunnel vision, it will never get worse. It will stay stable. The name of the game, we want to keep the average pressure below 18. He was 11 or 12, and then he ran out of his drops. And he came in and said, yeah, I got busy, ran out of my drops. His pressures were not terrible. They were about 17. But in his weaker eye with this tunnel vision, it appeared that the area that was close to the center temporarily became almost closed. And he was still reading about 20/20 in his good eye, and his bad eye, he could only see the large number, the largest number on the chart, 2400 we call it. So I explained everything to him, and I said, listen, you have to get back on these drops. I want to see you tomorrow. Mm-hmm. And he came back. His pressures were in the low teens. He was about the same. So I said, come back in a few more days. He was doing well. He wasn't running out of the drops. And within several days, that where he could only see the 2400 came right back to about 20, 25, very close to normal. That's not the typical outcome. Most people are not nearly as aware of their deficit, but that was a very striking example of how much the vision can change if you have, and it was also a good example, many patients with glaucoma, they have a good eye and a bad eye, though it's asymmetric. And so, it really, emphasized to me the importance of compliance, and it can be very easy. Life gets in the way, life gets very busy. You really have to, especially if you have cases like this, you have to be, listen to what the doctor says. And also the other thing, many experts, the latest I heard was a very good anecdote from one of the professors at UCSF, who's a glaucoma specialist. He made a statement basically that it's not, and I think this goes for blood pressure too, it's not necessarily the absolute number that you get every time. It's mainly, you have to see, in my case, the glaucoma specialist regularly, because we don't know in each individual patient, does their eye pressure have to be exactly 12? Many patients will do fine if it averages 16 or 17. In this particular gentleman, I happen to be able to measure and document that 11 or 12 pressures were very good for this eye, and boom, when he ran out of his drops and his pressure went up only to 18, which is not terrible, all of a sudden the vision gets drastically different. So
this is really interesting, Dr. Hosler. The story is very interesting, that patients really do not realize how they are seeing from one eye, which is affected eye.
Especially if their other eye is good. And the brain can kind of compensate.
Yeah, so I think it gives a message to our viewer that from time to time, they need to cover one eye and see how they are seeing, and alternate it and see how is your vision. And if you see a change, then it's time to go for your eye exam.
That's a great point, especially in diabetics. So I touched on very briefly that one of the things diabetic blood vessels can do is leak into the retina. What I just described with my glaucoma patients, I see, a few times a year where you can be developing a little bit of blood vessel leakage in one eye, and it can cause a lot of visual deficit. But if you have your better eye, so everyone has a dominant eye and a non-dominant eye. Particularly if you have early damage in your non-dominant eye, a lot can happen where you don't realize it. And you actually made a perfect point. I probably would have mentioned it later on, that that's an excellent trick. In fact, you may have seen something called an Amsler grid, or if your patients have macular degeneration and it hasn't been discussed lately, you can go on the internet and type in Amsler grid, AMSLER, and grid just means, boxes. It's an Amsler grid. One of really a big key to that test is covering one eye and covering the other. And it's a great way for early detection of weakness that's only in one eye. And you can really, I've seen patients catch something 6 months before they were due for their next eye checkup, and they can get a jump on treating it.
That's a great tip, Dr. Hosler. So I actually want you to elaborate on the word that you said in the previous sentence, because many of our viewers would like to know, what do you mean by macular degeneration?
Right.
This is also not a very familiar terminology with many, unless someone gets diagnosed with it, and then they become more aware of it. Right. But I think prevention is a great strategy as far as macular degeneration is concerned. So if you can just give our viewers a little bit more information on this disease again, which is a very damaging disease, and it can really affect vision and it can lead to blindness.
Right. So first of all, I would say that about 90% of all patients with macular degeneration have the dry form. And I'll explain that now. So if you think of the eyeball as a sphere, and I'll turn it as if the sphere is looking, the front of the eye is here. There's a clear cornea on the front of your eye and the lens right behind that. When you get a cataract, it's the lens toward the front of the eye. Coating the inside back of the eye is a sheet of photoreceptors, and it's sort of like wallpaper. The dead center of that wallpaper, but it's not just decorative, obviously. This wallpaper has these photoreceptors that detect the image of the world. The dead center is called the fovea, which is in the center of the macula. And that's where it's the anatomic feature of the macula that induces, or whatever is the basis of the name, macular degeneration. It's retinal damage or degeneration from age. In fact, the term is age-related macular degeneration. It's the central vision or the central retina, and that's the center of the retina is what we use when we read. When we look at a letter, it's that central vision. We're focusing on the letters that we're reading, and that's subtended by the center of the retina. The dry form of macular degeneration is where metabolic byproducts of the basic function of these photoreceptors can build up in little pockets the byproducts are called lipofuscin pigment. And when they collect to a large enough degree that they become visible in the microscope, the little pockets look like little yellow dots in the central retina, in the macula. They're called drusen. And I just mention it in this way because many of your patients, or your viewers rather, who have gotten a basic eye exam, if they're over age 50, they may have been told, yes, you have dry macular degeneration. It's not necessarily something to panic about, because 90% of the patients have the dry form, but that form only causes 10% of the major vision loss. That's the milder form of macular degeneration. So any patients who have that should be seen usually at least annually. And, what I tell my patients when they have it, if they have a moderate form or worse, sometimes mild, it depends on the specialist, many patients will be advised to take what they call the eye vitamin or Preservision. Those vitamins contain lutein. Mm-hmm. Older forms used to contain zeaxanthine. These compounds are really basically antioxidant molecules that are found, that are very abundant in orange and green vegetables. So if an eye doctor tells one of your patients that they have very early dry macular degeneration, I tell many of my patients, or if a patient has a parent who has macular degeneration, I'll say, you can do the eye vitamin if you want. You can also get lutein in the form of something like Centrum Silver. Mm-hmm. Or you can just try to increase your consumption of dark green and orange vegetables.
So, question, Dr. Hosler. This was actually the next question, but you were really proactive and you talked about the eye vitamins.
Yeah.
So lutein is like the most popular. Yes. I would say that it is prescribed in almost all patients who have either hypertension or diabetes, and especially if they are above 50, correct?
Right. Yes.
So what is the role of vitamin A? And my question is actually that, do we receive enough eye vitamin in our diet? Is it enough? Or do we really need to take supplements such as vitamin A, lutein, or any other vitamins which are in the market, which are over the counter? And will it help?
Right. So the role of vitamin A supplements in the stabilization or improvement of macular degeneration really is not proven. In my opinion, lutein or zeaxanthine supplements are decent substitutes in patients, let's say, who can't afford a good diet with whole fruits and vegetables, or if they just hate to eat whole fruits. There's a lot of people who hate salad and they hate vegetables. And a lot of us, I hate to say it, in this country, we live a life of with our diets of convenience, where we don't try to fill our time with work. We're always trying to produce more. So I wouldn't push a vitamin A supplement by itself. Vitamin A, another term for that is retinol. The key pigments that your photoreceptors use are based on vitamin A. Vitamin A deficiency is actually quite rare in the United States. So what we're talking about here with a lutein supplement is to really act as an insurance policy for patients who rarely eat salad or really don't get very many servings of whole fruits and vegetables. So yeah, if I tell my patients, if you have a good diet, some patients will say, yeah, I eat at least one green salad every day. If they have no macular degeneration or very, very mild, a lot of times I'll say you can take a lutein supplement or a Centrum Silver with lutein if you want, but your diet is really probably doing most of what you need.
Wonderful. So Dr. Hosler, that was actually a very good tip about how to manage eye health through prevention.
Yes.
And next question is about sun exposure. and
Okay.
protecting eyes from sun.
That's a great question.
What would you recommend?
So there have been a number of studies over the years that suggest that, for instance, that the populations who live closer to the equator, the study I'm thinking of was done in Australia, and they found that there were higher rates of cataract formation, and cataracts occurred at younger ages than similar cohorts in populations that live farther from the equator. These aren't perfect studies, but this evidence suggests that if your skin and eyes in particular, are exposed to more sunlight, it may lead to cataract formation. Similar studies have shown the same thing with macular degeneration. So if you, for instance, if you're just worried about your vision, or particularly if you have a parent who had cataracts or macular degeneration, along with a good diet that we've mentioned, you can sometimes find contact lenses that block ultraviolet. Many prescription eyeglasses block UV. Or if you're, particularly if you're younger and you don't need prescription glasses to drive or see the television, most non-prescription over-the-counter sunglasses block UVA and UVB. I think the role of UVC blocking is less well understood, but beside that, so protecting your eyes with glasses, contacts, or sunglasses to reduce or minimize UV exposure directly into your eyes. You don't really think of it that much, but a hat with a brim, if you work outside all day, can work together with glasses or contacts to reduce your sun exposure into your eyes. And yeah, there's definitely evidence to suggest that excess UV can potentially cause premature cataracts, or maybe increase your chances of developing macular degeneration, for sure.
Thank you, Dr. Hosler. I am very fanatic about taking my sunglasses and a visor because whenever I'm outside,
Great.
So I'm happy that I'm doing the right thing.
You are.
And our viewers, yes, they have learned something, that if you are going out in sun, if you are going to be outdoor for a long time, then carry two things, sunglasses, which are UV protective, and a visor, so that you are keeping your eyes cool too from the sun, from the heat.
Yep.
So coming to the summarizing this session of your presentation about eye health.
Yes.
If you have to give a message to all our viewers in a nutshell, what would you say?
I would say that the primary care system for our children, I think, does a good job at screening for the needs for mild needs for eyeglasses. And the majority of children under the age of 5, if they have something that's not a mild need for glasses, they usually will show the signs that I outlined. You can tell they can't see something, or they're squinting, or they have a misalignment, or as I mentioned, the leukocoria, the white pupil. Those things need brought to the attention promptly of a pediatrician or a pediatric ophthalmologist. And I think we all should be eating a good diet. Someone like you who runs a stroke center, I'm sure you see all the time the correlation between not ideal diet, obesity, smoking. Smoking, when we talk about the connection between UV exposure, cataracts, and macular degeneration, smoking is right in there. So that's why I mentioned, we talked at the beginning that, what is eye health? Well, it's really an extension of the health of your whole body. And so it's a little repetitious between what I'm sure you tell your patients all the time, which is we all should be keeping our weight down. We all should be exercising, and we all should be promoting a good diet. To summarize that, I pushed it quite a bit already not to be repetitious, but a diet rich in whole fruits and vegetables for macular degeneration, particularly dark greens and dark orange vegetables, minimizing foods that have poor nutrition, particularly white bread, white rice, processed carbohydrates and sugars, reducing that. And it's a little controversial at this point, but there's a lot of questions that dairy may be less beneficial for you. So I think not most nutrition experts would agree that a diet very rich in dairy, dairy in moderation is okay, but it's not good as a staple of your diet. All these things can reduce your risk of heart disease, stroke, and eye disease. And then I'll just reiterate, if you've never had to wear glasses for driving, you only started to wear readers in your 40s, just make sure you try to see an eye doctor within your 40s. Waiting until your 50s or later to have your first eye exam is risky. And I think that's, that kind of sums it up right there. And those are things I do for myself. I have elevated cholesterol by trying to improve the quality of my diet and keep my weight down. I've stayed off cholesterol medicines, and I think you just can't go wrong with, making it a goal to increase your exercise and improve the quality of your diet.
That's a wonderful summation, Dr. Hosler. What you said, it's almost you are sharing this knowledge, incorporating all the integrative medicine practices coming from an ophthalmologist. You are not just focusing on eye health, like not just an organ related discussion here. What you are talking about is that our vision is outcome of what we do as a whole.
Absolutely.
So our vision, which is so precious, our eyesight is so precious because nobody wants to lose it. And in order to maintain that, you suggested not just the visit annually to see your eye doctor, but look at your overall lifestyle. Make sure your diet is consisting of healthy food. And then you also mentioned how to control your dyslipidemia, cholesterol. You can manage it through diet.
Yep.
You can do it through physical activity and choosing the right food.
Yes.
And so it's really interesting that you incorporate all those interdisciplinary advices as well. And
Yep.
your patients must be getting a lot of benefit, all-in-one benefit when they visit you.
Yeah.
So thank you for sharing your perspective. Thank you for sharing all your expertise about all eye condition. And to my viewers, I would say this is a great information that came from our special guest, Dr. Mathew Hosler, who is a certified ophthalmologist, glaucoma specialist, a cataract surgeon, and not to forget, he teaches. That's how he's such a great speaker. He teaches as a faculty at Seton Hall University. So we are learning from someone who has been teaching it to budding and our future ophthalmologists. So we are so honored to have Dr. Hosler in this show. And I hope you learned a lot in this episode, which was focused on eye health. And you come back to us with your questions and suggestions, because we may want to bring back Dr. Hosler to answer some of your questions.
Yeah, I'd love to do that. I'd be happy to. It's been very enjoyable. Thank you for the invitation, Marcia.
Thank you so much for your time and everything that you shared with us on this show, Healthline, on TVAsia Telugu channel. To my viewers, when we come back in our next episode, we will have equally interesting and very helpful information for you. So stay tuned. Don't miss any episode of Healthline, because the amount of information and the kind of special guests that we bring to you is phenomenally good. I hope you enjoyed this. Till next time, I'll see you again, your host, Varsha Singh, saying bye for now. Thank you.
Thank you. Goodbye. Thank you.